nice presentation with Dr. Yamen about hypothermia and for the treatment of hypoxic ischemic encephalopathy. Okay. Thank you, Dr. Yamen, for your preparation, and please go on. We are awaiting to hear from you.
Thanks, Dr. Muhammad. Good morning, everybody. So today I feel this topic is interesting. That's why I'm going to present it today. Regarding the therapeutic hypothermia, there's nothing to be disclosed here. I will go through the brief definitions, pathogenesis, role of the hypothermia, inclusion, exclusion, and indication when to stop therapeutic hypothermia, which method should be used to provide hypothermia, and when should cooling be initiated and when should be stopped, what follow-up should be organized for infant who receive hypothermia, and what is the optimal timing for brain imaging, care during therapeutic hypothermia, outcome, and controversy debates. Slides start to be showed. Everybody seeing the slides?
No, not yet, Dr. Yamen. I didn't see it. Maybe I don't know whether our colleagues they can see.
Slides not seen.
I think Asma, she is arranging now.
Okay, now seen, Dr. Yamen.
Okay. Yeah. Okay, Asma will go to the first slides. Next. Okay. All right. So we'll go through the definition to make it more clear and easier whenever we are talking about HIE, encephalopathy, perinatal asphyxia. So perinatal asphyxia is it's an event happening or occurring during the second stage of labor, in which impaired gas exchange lead to fetal acidosis, hypoxia, and hypercarbia. Perinatal hypoxia, ischemia, and asphyxia. This is describing respectively a decrease in oxygen, blood flow, and gas exchange to the fetus or newborn. Perinatal neonatal depression is a clinical descriptive term that patient the condition of infant on the physical examination in the immediate postnatal period. Neonatal encephalopathy is a clinical, it's not an etiological term, that describing an abnormal neurobehavioral state consisting of an altered level of consciousness, either depressed or hyper-alert. Usual other signs of brainstem or motor dysfunction. Next, Asma. Hypoxic ischemic encephalopathy, HIE, is the term that describes clinical evidence of encephalopathy as defined earlier, with an objective data to support the hypoxic ischemic injury mechanism as underlying cause for encephalopathy. Hypoxic brain injury refers to a neuropathology attributable to hypoxia ischemia as evidenced by neuroimaging, CT scan, MRI, MRS, to confirm the diagnosis. So next slide. Yeah. So what's happening here during the hypoxic ischemic encephalopathy? Have two columns. We'll be having respiratory depression and circulatory depression. In the respiratory depression, there's hypoxia, hypercarbia, and respiratory acidosis. The circulatory depression, there's low cardiac output, decreased tissue perfusion, ischemia, metabolic acidosis, capillary leak. All of this going all together to multi-organ dysfunction at the level of brain, leading to encephalopathy, abnormal neurological signs and seizures, respiratory failure with persistent pulmonary hypertension, myocardial dysfunction, hypotension, metabolic hypoglycemia, hypocalcemia, and hyponatremia. and other organ dysfunction like renal failure, acute tuberous necrosis, and hematological DIC and coagulopathy. Next. The incidence of hypoxic ischemic encephalopathy here is 2 to 3 per 1,000 live birth in developed countries and 26 per 1,000 live birth in low middle income countries. A higher incidence is noted in newborn of diabetic or toxemic mother, those with intrauterine growth restriction, breech presentation newborn who are post-date. So what happened during the asphyxia? What happening to the brain? There is different stages over here. We have primary and tertiary energy failure. In the primary energy failure, first 60 minutes here, following the ischemic injury, there's which happening here, there's enriching rich in adenosine substances. And triphosphate is depleted, apoptosis leading to necrosis, and of the cells will be start to occur over there in the first 60 minutes of the depression or asphyxia. In the latent phase, which is between 1 and 6 hours of injury, during resuscitation, is partial restoration of cerebral perfusion and oxygenation with a partial restoration of energy sources. The secondary energy failure, which is occurring between 6 to 48 hours, which is happening here, the reperfusion injury. Reperfusion injury here leading to bringing up the inflammatory mediators and free radicals promoting inflammation and oxidative and cytotoxic damage. And the tertiary energy failure here, which end up with late cell death and gliosis will be taking place over here. Next, Asma. Okay. I summarized here in these slides. Yeah, you can see in the slide the acute phase at the top of the slides, acute phase, latent, secondary phase, and tertiary phases. You can see here whenever there's the insult of hypoxia, the changes will occurring at the level of the brain due to anaerobic metabolism. And in the latent phase, you can see the cell death and apoptotic pathway started, inflammation, oxidative stress, excitotoxicity. And here we'll start to see at the 30-minute reperfusion. So after the ischemia, there's what we call the reperfusion injury. Then hypoperfusion between 6 to 15 hours with cytotoxic edema. In the secondary phase and tertiary phase, there will be happening remodeling, astrogliosis, and late cell death. So here in the down of the diagram, you can see the therapeutic window between 6 to 15 hours. And the ideal is the first 6 hours of. Okay. So here we can, at the base of the diagram, you can see the therapeutic window between 30 and the first 6 hours of the baby age. Next, Asma. So as I mentioned, after the ischemic period of hypoxia, which is the brain start to suffer during the insult, there is something called reperfusion of the previously ischemic tissue. And that may cause further injury by promoting the formation of excessively active oxygen species, superoxide, hydrogen peroxide, and hydroxyl and singlet oxygen, which can overwhelm the endogenous scavengers mechanism, thereby causing damage to the cellular lipid, protein, nucleic acid, as well as to the blood-brain barrier. This may result in influx of neutrophil that, along with activated microglia, release injurious cytokines like interleukin 1B and tumor necrosis factor A. Next. So what's happening at the level of biochemical and pathological? What change is happening here during the asphyxia? So there will be reduced in oxygen supply, anaerobic gliosis, decrease in high energy phosphate, accumulation of lactate, failure of sodium potassium ATPase pump, cell swelling and necrosis, calcium entry into the cell, and formation of free radicals like nitric oxide synthesis and lipid pre-oxidation. talk about therapeutic hypothermia, we should know what is the role of hypothermia. So therapeutic hypothermia has been shown to be a neuroprotective in term and near-term neonate with a moderate to severe hypoxic ischemic encephalopathy. And the mechanism here will therapeutic hypothermia leading to decrease in the tissue metabolic demand, including cerebral metabolic rate, decrease in ionic perturbation with decreased intracellular calcium influx and mitochondrial dysfunction, and thereby neurotoxicity, the same time leading to decrease in the free radical productions. So this is the role of therapeutic hypothermia with attenuation of pro-inflammatory cascade activation. Next. Okay. When we apply the therapeutic hypothermia to treat hypoxic ischemic encephalopathy, happening through the 4 phases. First, the induction phase, during which the core temperature is rapidly decreased to a gold limit, 34 to 33 Celsius, and to maintain this phase. After that, the whole body cooling at 34 to 35. There is 2 modality of cooling of the baby, either selective head cooling or total body cooling. A rewarming phase during which the core temperature is slowly increased. A rewarming rate is not more than 0.5 Celsius or less per hour are recommended to avoid temperature overshoot and rebound seizures. So here we have to take care during rewarming. Sometimes we do attach EEG monitoring during the during the rewarming process to avoid seizures activity, either electrically recorded or by clinical findings. Next, Asma. Which method should be used to provide hypothermia? As I mentioned, there's 2 methods of cooling have been used in the clinical trial, either selective head cooling and whole body cooling. One small single center trial compared both methods of cooling and found no difference in outcome at 12 months of age in infants enrolled. A larger clinical trial on death and disability outcome when either method was compared with a placebo. But when we go to the whole body cooling, nowadays is more recommended because it is easier to set up and use and less expensive, provides better access to EEG, and is more readily available. This is level 1 evidence in the Pediatric Child Health 2018. When should cooling be initiated? So here, while awaiting transport to a tertiary care unit, initiation of passive cooling, like removing the infant's hat, blankets, turning off the overhead warmer, should be strongly considered in community hospital following consultation with a receiving neonatologist. Rectal, not possible. Auxiliary temperature should be monitored every 15 minutes to ensure the infant temperature does not decrease below 33 Celsius. The use of ice bag or cool gel by untrained personnel, which can lead to severe hypothermia, is not recommended nowadays. Can hypothermia be provided to a preterm infant? Hypothermia is associated with increased mortality in preterm infants. There is currently no evidence that therapeutic hypothermia offers any benefit to infants younger than 35 weeks. A few infants as young as 35-week gestation age were included in some clinical trials, and some Canadian centers offer this therapy to infants at 35 and plus gestational age. This evidence form. As we know, the indication of hypothermia, all of you, I think, know this slides. So 36 weeks and above, a core BH below 7, or BH 7 to 7.15, or base deficit -10 to -15.9 on cord gas or blood gas within 1 hour, with a history of acute perinatal events like cord prolapse, placental abruption, uterine rupture. Apgar score less than 5 at 10 minutes, and at least 10 minutes of positive pressure ventilation, with the evidence of moderate to severe encephalopathy according to SARNet classifications. Next slide. Next. So this is a SARNet criteria. No, before. Yes. This is SARNet criteria classification has been implemented by a Canadian doctors in 1976 to actually this is the modified one, updated one, and that will make us in the good track where we are. We are in the mild, we are in the moderate, we are in severe hypoxic ischemic encephalopathy according to the classification assessment of the baby within the first 6 hours of after the delivery. Next slide. Yeah. I found this table is very interesting and helpful for all of us. This is from a Canadian hospital, from Health Science Center, to keep on assessing the baby for any baby has been suspected to have hypoxic ischemic encephalopathy or perinatal asphyxia. So we are just attaching this baby on the baby in the attaching this table with the baby bed, and we should keep on assessing the baby every 1 hour to see. Initially, he might not fulfilling the criteria of calling, but maybe at 3 hours of baby age, he start to develop signs of symptoms of moderate to severe encephalopathy, and we can start calling. So means baby is not fulfilling the criteria initially, is not omit that or not excluded that this baby is not suffered, or he might not need therapeutic hypothermia. So a frequent assessment every 1 hour is very important in the initial 6 hours of the baby life when we suspect that this baby suffered perinatal asphyxia. It's not a matter to bring him, apply the guideline, baby is not fulfilling, and leave the baby without any assessment. We should keep on assessing according to this check marks. Then we can decide either the baby fulfilling the criteria of calling therapeutic hypothermia or not. Next slide. Of course, all of us, we know the exclusion criteria. A morbid infant or infant with major congenital or genetic abnormality. We have infant with severe intrauterine growth restriction, infant with a clinical significance of coagulopathy, and infant with evidence of severe head trauma or intracranial bleeding. Isolated intraventricular hemorrhage may not constitute an absolute contraindication. However, this guidance is based on a very limited evidence. What are the side effects of hypothermia? Infant who receive hypothermia having a chance to develop sinus bradycardia, hypotension with possible need of inotropic support, microthrombocytopenia with persistent pulmonary hypertension and impaired oxygenation. Hypothermia also can prolong bleeding time leading to coagulopathy. They are more prone to arrhythmia, anemia, leukopenia, hypoglycemia, hypokalemia, urinary retention, coagulopathy, and subcutaneous fat necrosis. We had recently a baby admitted with perinatal asphyxia, and at day 3 of his life, developed subcutaneous fat necrosis involving his upper back and both shoulder, associated with persistent hypercalcemia, and almost resolved after 1 month with conservative management and care. Next. So when to stop the hypothermia? Now you start to cool the baby and things going as you wish, but at any time you should think when to stop or something happened to the baby during hypothermia, because hypothermia itself having a high side effect and baby might deteriorate at any time. So if there's any hypotension or refractory shock, despite in the baby is on inotropic support, should think to stop hypothermia. Persistent pulmonary hypertension with hypoxemia, despite adequate treatment, again, this is one of the indications to stop hypothermia. Clinically significant coagulopathy, despite the treatment, again, this is an indication to stop hypothermia. Subcutaneous fat necrosis with or without hypercalcemia has been reported as a potential rare complication. Cooling is stopped uncommonly due to complication. Like very rarely we are stopping cooling. Is among the percentage is than 10%. But this is like a brief idea when to stop the cooling process whenever you are being started. This is according to Pediatric and Child Health published on 2018. The evidence is 2A. Now you put the baby on cooling. What you should do during the cooling process? What care should be given to the baby? First of all, a core temperature should be monitored continuously and documented every 15 minutes until 1 hour after goal temperature reach 33.5 Celsius is achieved. At the end of 72 hours of induced hypothermia, the newborn is rewarmed as 1.5 Celsius every 2 hours until the newborn reach 36.5, and that should not take more than 10 to 12 hours. If a newborn is discovered to meet an exclusion criteria or undergoes a major adverse event while undergoing hypothermia, rewarming should be again according to the same procedure. So just not to disconnect all of a sudden the baby from the cooling machine. You should start rewarming the baby, although he's having the complication of hypothermia. During the rewarming procedure, a core temperature should be monitored continuously and documented every 1 hour. At the respiratory level here, we should monitor blood gas and lactate at the baseline, then at 4, 8, 12, 24, 48 hours, and 72 hours of treatment, and as clinically indicated. Maintain adequate ventilation, avoid hypoxia and hyperoxia, because both they are very nasty to the brain tissue. For persistent pulmonary hypertension, use high-frequency ventilation, nitric oxide, or ECMO in case baby is not responding. Next, Asma. Yeah, this slide also will summarize what's happening during the asphyxia and during the hypothermia. So asphyxiated baby, as we know, he will develop apnea. He might have a chance of PPHN. He might having meconium aspiration, RDS, pulmonary hemorrhage. The hypothermia itself lead to decreased oxygen consumption, increased minute ventilation, and increased surfactant activity. So all this going to the lungs here. Now, if in case you hyperoxygenate the baby, lead to increasing oxidative stress and inflammatory mediators. But if you hypooxygenated of the baby or baby start to have hypocapnia, again leading to a neuronal excitability, cerebral vasoconstriction, and apoptotic cell death. So it's not a matter to keep the baby on the ventilator without a regular follow-up. You should monitor the baby clinically with the ventilator parameters and blood gas frequently to stabilize the level of oxygen and CO2 to avoid unnecessarily side effects of the hyperoxia or hypocapnia. Next, Asma. At the cardiovascular level, hemodynamics here is a big topic, and this is we'll talk in brief. So vital signs should be monitored and documented by routine. Arterial access and central venous access should be obtained prior to initiation of therapeutic hypothermia, and should be maintained initially before the starting cooling, because you will not get good access to the vein if the baby hypothermic. So this slide also summarizes the hemodynamic in the baby briefly. So echo is very important here to assess the hemodynamic of the baby, the ventricular function, the feeling process, and the ventricles. So like we sometimes consider fluid boluses as evidence of significant blood loss, but most of the time we are avoiding. First line, in case of low systolic blood pressure and normal diastolic blood pressure, dobutamine as a first agent started at 5 microgram per kg per minute and titrate upward. If diastolic blood pressure fall, we are adding nor-ibi. If there is no any available nitric oxide is not available, we can starting sildenafil per oral or IV. If the case there's pulmonary hypertension, we are starting INO, dobutamine if systolic dysfunction, nor-ibi if low vascular tone or low dose of epinephrine, Merinon in severe pulmonary hypertension with norepinephrine. So this based on your cardiologist assessment with echo initially when the baby came to the unit and with frequent follow-up. So this is slides getting from review by Glessinger at 2017. I hope that will be helpful for you. So what happened at the level of the hematology? So we are, as we mentioned, we are suspecting a patient having coagulopathy. So how to avoid bleeding or unexpected bleeding diathesis or chance of hemorrhage in case of hypothermia. So the laboratory evidence of coagulopathy is in universal hypoxic ischemic babies undergoing therapeutic hypothermia, a transfusion strategy to maintain platelet count above 130,000, fibrinogen level above 1.5 gram per liter, and INR should be below 2. This all may prevent bleeding in this high-risk population. And this has been published in Children's National Medical Center in Washington, 2014. Infectious disease, usually also we are adding antibiotic. We are sending septic workup and routine blood investigation. If there's concern regarding renal function, we are changing the gentamicin to cefotaxime instead. Next. Fluid and electrolytes. So MBO, when a passive cooling starts, typically until warm to normal temperature, glucose, serum electrolyte with calcium, blood urine nitrogen, liver function test as a baseline, then at every 24 to 48 hours, and then at 72 hours, and is according clinical indication. There are some centers providing low volume trophic feed or gut priming as 10 ml per kg if there are no direct contraindications such as hypotension. To avoid cerebral edema in this rescue baby with the goal of sodium level at high end of normal range, because many of these newborn have decreased urine output of due to multifactorial etiology, anticipating need for a relative fluid restriction will assist in avoiding serum sodium below 140. So the target here of sodium level should be in the upper range all the time during therapeutic hypothermia. Next. Hypoglycemia and hyperglycemia might be happen both. So the neonatal period, during the neonatal period, the brain utilizes around 70% or more of glucose produced by the liver. Exposure to hypoxic ischemic stress lead to a switch from aerobic to anaerobic metabolism, and in turn decrease glucose delivery in proportion to the degree of asphyxia because of limited energy store in neonate as well as an immature center regulatory response. This results in hypoglycemia. Studies indicated that both hypoglycemia and hyperglycemia are associated with poor outcome in newborn with HIE. However, there are no randomized clinical trials to guide the clinician as to what the optimal glucose level target should be in the newborn with HIE. Next. The neurological status, this is the most important part. As long as you have the facility of neurology consultation, do it as soon as possible. According to American Academy of Pediatric guidelines, specifically recommend that neurology consultation, EEG monitoring, neuroimaging, including MRI, and longitudinal neurodevelopmental follow-up be available for a center offering hypothermia. An EEG or preferably full EEG study should be initiated on admission and continued through the at least 24 hours. The 12-hour rewarming and during the 12-hour of rewarming process, and potentially throughout the entire hypothermia protocol. So EEG is very important during induction of the hypothermia, during the hypothermia treatment management, and during the rewarming also is very important to detect if there's any chance of seizures activity. Coronary ultrasound initially advised to be done by the baby in therapeutic hypothermia to assess if there is any intracranial hemorrhage. Next. So what is the optimal timing to do brain MRI? Performing an MRI in an infant undergoing active cooling is a challenge. You need to maintain a steady temperature and the compatibility of thermoregulation equipment with the MRI machine. In the absence of MRI compatible isolate and other specialized equipment, it is recommended to obtain an MRI once rewarming has been taken place. So in day 4 to 5 of life after finishing the cooling process. Like we finish at 72 hours, the next day or the day after, this is the recommended time to do a brain MRI. Consider a repeat MRI between day 10 and 14 of life when the image and clinical features are discordant or when diagnostic ambiguity is still persists. This evidence level 3. So we have early MRI and we have late MRI, as we mentioned. So late MRI, brain MRIs can be useful to detect severity and location of hypoxic brain injury, which is the best to determine by conventional T1, T2 weighted image sequence at 10 to 14 days of age or older. Note that diffusion abnormality detected by diffusion study will pseudo-normalize, appear normal at approximately 7 to 10 days following hypoxic brain insult, and following that a diffusion study sequence may show increased diffusion in area of established hypoxic brain injury. EEGs we talk about, but now we'll just go in brief to explain. If the exam show encephalopathy, an EEG can be performed to provide further assessment for the severity of encephalopathy. A normal neurological exam does not require confirmation by EEG. But in some circumstances in which physical exam is unreliable, an EEG should be performed to determine if there is encephalopathy. Next. The clinical EEG findings correspond to each stage, are not necessarily specific to etiology of HIE, but are manifestation of cerebral dysfunction that may occur with any newborn encephalopathy. EEG correlated with the degree of encephalopathy in neurological examination, but was not specific to hypoxic ischemia as the cause of encephalopathy. Next. Here we have Al-Naqib and colleague classification, basic classification system based on the voltage assessment as a follows. We have a normal, we have a moderate and suppressed or severe encephalopathy, and I just summarized in this slide. We have the normal lower margin above 5 and above 10. This is considered normal, which is called continuous normal voltage. You can see on the right side, and this continuous normal voltage, this considered in mild and normal and moderate abnormal. So might be continuous normal voltage and might be discontinuous normal voltage in case of moderate abnormal, which is lower margin below 5 and upper margin above 10. When we go to the severe abnormalities both lower margin, the lower margin below 5 and the upper margin also again below 10. So and you can see here the low voltage and flat trace, this again indicating the severity of the insult which is happening to the baby. Pulse suppression, you might find it also in moderate abnormality in case of hypoxic ischemic encephalopathy. So the orange color starting to be abnormal till down tracing flat EEG. I hope that slide is clear for you. So seizure control is very important here. So according to the Seminar in Fetal and Neonatal Medicine published in 2021, they found that phenobarbital remain a mainstay of treatment as it is a more effective than Keppra and easier to administer than phosphoenolitoin. Emerging evidence suggests that for many neonates, it is the safest for the baby during therapeutic hypothermia. Phenobarbital after acute seizure resolve and period to hospital discharge also considered to be more safe and with less side effect during the therapeutic hypothermia. So phenobarbital is drug of a choice for seizure control during therapeutic hypothermia. Of course, baby who is subjected to therapeutic hypothermia, he will having painful stimuli, so sedation should be started here. A low dose of morphine or fentanyl is effective. Hypothermia and potentially hepatic dysfunction reduce the necrotic metabolism. Therefore, careful attention must be paid to avoid excessive narcotic level. Some centers using dexmedetomidine, although there are few data regarding its use safety in the newborn. Next slide. There is a potential neuroprotective agent such as erythropoietin, melatonin, xenon, and stem cell that are undergoing evaluation in phase 1, 2, 3 trial, but there are currently no data supporting the use of any agent besides therapeutic hypothermia for neuroprotective modalities. What follow-up? Next slide. What follow-up should be organized for infants who receive therapeutic hypothermia? So the follow-up should be continued for 18 to 24 months. Has been standard for care in any patient underwent hypothermia, therapeutic hypothermia. A multidisciplinary follow-up could involve a neonatologist, pediatrician, physiotherapist, occupational therapist, psychology, an infant developmental program, neurology, developmental pediatrician, ophthalmology, and audiology. A specialist working together to assess long-term motor, psychoeducational, auditory, and cognitive outcome is an important care component for infants who have received therapeutic hypothermia. Next. The outcome of perinatal asphyxia. The level of mild perinatal asphyxia, there is a chance of mortality. The chance of mortality is less than 1%, and 98 to 100% newborn will have a normal neurological outcome. While the moderate hypoxic ischemic encephalopathy, 20 to 37% will die or have abnormal neurodevelopmental outcome. And the prognosis again will be guided by EEG and MRI studies. Severe HIE, death from effect of severe systemic asphyxia, is more common with severe HIE. Survivors with MRI evidence of significant hypoxic brain injury are likely to have one or more major neurodevelopmental disabilities such as CP, intellectual disability, cerebral visual impairment, or epilepsy. The secondary outcome of perinatal asphyxia. The presence of seizure is associated with significantly increased risk for late epilepsy and intellectual and motor disability. Mortality and long-term morbidity are highest for seizures that begin within 12 hours of birth. Persistently low voltage activity or isoelectric background by EEG is a prognostic indicator of poor neurological outcome. Although a transient pulse suppression pattern may be associated with a good outcome, a persistent pulse suppression pattern is associated with high risk of death or neurodevelopmental disability again. The debate about therapeutic hypothermia now, to cool or not to cool of a patient with mild hypoxic ischemic encephalopathy. There's a greatest area of controversy here is whether to offer hypothermia to a newborn who have mild degree of encephalopathy. Although there are some objective criteria such as pH, base excess voltage by EEG, or other criteria are necessarily subjective, such as a determination of fetal neonatal distress or severity of encephalopathy by clinical exam. The threshold for which hypothermia may provide benefit without adverse effect may somewhat different from that which was studied in published clinical trial, which included few or newborn with a mild encephalopathy. Further data are clearly needed regarding the neurological outcome of a newborn with mild HIE and the risk and benefit of hypothermia for mild HIE. There are ongoing prospective studies and trials which may provide this data in the coming years. Late initiation of hypothermia, there are data showing that hypothermia is associated with improved outcome if started at 3 to 4 hours after birth, consistent with animal data studies, but it is unclear if there is a benefit to hypothermia initiated after the 6 hours of the baby age. This question was tested in a trial funded by National Institute of Child Health and Human Development that showed a small probability of additional benefit of cooling starting at between 6 to 24 hours after birth. Many centers do consider cooling infant beginning at 6 to 12 hours if other criteria has been met. So still we have a window up to 12 hours and to consider therapeutic hypothermia. My summary for topic today: infant about the therapeutic hypothermia infant about 36-week gestation with moderate to severe HIE who meet the inclusion criteria should receive therapeutic hypothermia. Therapeutic hypothermia should be continued for 72 hours with a target rectal or esophageal temperature 33 to 34 Celsius for whole body cooling and 34 to 35 Celsius for selective heat cooling. Therapeutic hypothermia in infant younger than 35 weeks is not recommended. Infant above 35 weeks gestation with moderate to severe HIE who met other inclusion criteria should be considered for therapeutic hypothermia. Treatment of pain or discomfort during cooling with low-dose opioid is recommended. Follow-up of the infant who received hypothermia to a minimum of 2 years, but ideally until school age. Neonatal follow-up clinic is recommended. Both selective heat cooling, whole body cooling are effective. Whole body cooling is easier, set up and use, less expensive, provide access to the EEG, and therefore recommended for center not currently using selective heat cooling. This is my references. Any questions?
Okay, thank you, Dr. Yamen, for this illustrative and actually a good diet about neonatal hypoxic ischemic encephalopathy. My point is that, Dr. Yamen, is that once we start cooling and baby had convulsion and you started on phenobarbital, on the baby had pain and you started on opioid, did you recommend following up drug level for phenobarb, or we can just wait for some time?
Yeah, based on the patient clinical status, at any time we feel the baby is knocked down and the level of consciousness is further deteriorated, so we should think to send phenobarb level. But initially, we are not sending unless if the baby has been completely knocked down and we feel the baby's neurological assessment is subconscious. There's no any activity or anything. So what the first thing we should do to send for the phenobarbital level. Otherwise, we will load the baby initially and we'll wait. If it's happening again, we will load and keep him maintenance. After that, we come and assess for the drug medication level and clinical assessment, neurological assessment for the baby. But Dr. Muhammad, take into account that even the metabolic process for the drug metabolite will be also disturbed because the baby under cooling process, the liver will not functioning and the kidney will not function as a normal newborn who are not under therapeutic hypothermia.
So the drug metabolism, Dr. Yamen, will be affected. That's why many centers and many people, once you start phenobarbital, better to follow up with the level and just in order to adjust the dose, because at one stage the dose may be high, as you said, and the baby may be completely knocked down. The same as opioid also, opiate, especially if you are using morphine or fentanyl. Also, you need to give as much as low dose because the metabolism will be affected and the clearance for the drug from the body will take longer time. Shukran, Dr. Yamen.
Yes. Other questions?
Okay, thank you. تفضل.
Thank you so much. Thank you so much, Dr. Yamen. It was really amazing. You covered most of the aspects. Some few comments. As the amplitude integrated EEG is very crucial here. It has both diagnostics. So if you have any doubt that this is it mild encephalopathy or moderate to severe, so the amplitude integrated EEG will show you if the baby is having non-convulsive seizures or epileptic discharges, which the baby can be entered into the category of moderate to severe then, and then you have to cool. And it has also prognostic importance. So the baby was showing depressed tracing initially, and after 24 hours, the amplitude integrated EEG improving in the tracing, it became normal. So this is very, very, very good prognostic factor that the baby, alhamdulillah, he benefited from the therapeutic hypothermia, and he's going to to be better. One more thing, as regarding the so it's a very important criteria, the amplitude integrated EEG. So just and regarding the what you have mentioned in the debate regarding the other factors, the erythropoietin, there is a very recent study, maybe 2-3 months back now, published, that I'm not recall the study name. So now even erythropoietin, there was a hope that it can help as yeah, unfortunately now the erythropoietin is out of the calculation, so it's not showing any benefit. So now maybe the stem cells, especially the intranasal, using intranasal mesenchymal stem cell transplant post hypoxic ischemic encephalopathy, it can help. So let's hope, inshallah, for better future for those babies. Thank you so much.
Other questions?
Yes, Dr. Yamen.
Yes.
Thank you very much for it. Is nice, really nice and amazing lectures. My question is, where there is a hospital level 2 hospital where the therapeutic hypothermia not available. So what's the steps to be done until he reaches to the level 3 hospital?
Okay, thank you, doctor. As I mentioned earlier, the steps starting from the labor room or from the operation theater, by turning off the warmer, not to cover the baby, and at the same time keep on checking the baby temperature to avoid hypothermia. So we are not we are providing the passive cooling, but to avoid the temperature reaching below 33 Celsius. Nowadays, they are not recommending to go with active cooling, like putting an ice pack or gloves or fans. This is nowadays is not recommended because we are risking the baby. Just turn on the warmer off, expose the baby, don't put the hat, and keep on checking the temperature till you are arranging with the other facility for transferring the baby for the proper setup of therapeutic or cooling process.
I see. But in hot weather, there is something different.
Well, the baby will be in the hospital, then he will be in the ambulance.
Yeah. I mean, now you said that not putting ice bags or something like that.
Yeah, it's not recommended. Not recommended anymore.
Only passive cooling.
Passive cooling, yeah, just a passive cooling. I went through many articles trying to get approved guideline to apply an ice bag or gloves with water, or a fan to keep on fan, or direct AC to the baby, but is not recommended. All the studies has been omitted this practice a long time ago.
I see. Okay.
And as you said, Dr. Yamen, Dr. Yamen, the importance of the continual neurological assessment every hour with the SARNAT criteria. I think this table is very crucial. So the baby initially may be looking as a mild encephalopathy, but later on he will turn to be moderate to severe.
Exactly.
So, yeah, this is very crucial. So I think keeping this table with you, Dr. Adel, and in the other secondary care centers, and to keep assessing the baby once he is really fitting, we can start the passive cooling.
I see. Thank you very much.
Thanks. Other questions?
Yeah, good morning, Dr. Everybody. Thank you, Yamen. Very impressive presentation. So regarding starting cooling in level 2 units, like we used to do that for a long time when we transfer babies. So as soon as we receive consultation from the level 2 unit, as Dr. Yamen said, like the first thing to do is to turn off the heater of the resuscitator, and then to do everything that this baby needs, just like any other baby. Like if the baby needs any kind of ventilation, we should insert UAC, UVC at the best of our capacity. We should start monitoring as much as we can if we have NIRS, if we have a neuro critical monitoring. So all these should be started immediately with the extra point of turning off the resuscitator. So we all know that if the baby in the OR or in the labor room, definitely the temperature will be somewhere around 20 to 21. And again, the same thing in the ambulance. So, and again, it's absolutely contraindicated to put any kind of ice packs or anything, not only because of the bad hypothermia that this baby might have, but also because this is going to stimulate to make some sort of vagal stimulation, and you might induce apnea or seizures or whatever. So this, as mentioned, like they are absolutely contraindicated. And again, as Dr. Ahmed mentioned, this checklist that we used to use in Winnipeg, so this is very, very useful. And again, we kept doing this assessment till the 6 hours of age. And at that time will be the final decision whether to cool or not to cool the baby. So we still have this window, and rarely we exceeded the 6 hours window of cooling this baby. But I would still go with cooling this baby if we are between 6 and 7 hours and the baby was really in encephalopathic status. So these are the major two things, and again we should treat everything like seizures, keeping in mind like we have to avoid phenytoin as much as we can. Now we have the fosphenytoin, but just keep in mind that the phenytoin is absolutely contraindicated in hypothermia, and the phenobarb, as mentioned, is still number one. On the top of that, the hemodynamic stabilization again is very important, and the echo, use of echo, and the hemodynamic status of these babies is very important, and fluid restriction and following up the renal functions and the fluid balance in and out. Every single milliliter coming in and out of the baby should be measured accurately. Well done again, Dr. Yamen. Thank you.
Thanks. Other questions?
Okay, thank you, Dr. Yamen. Thank you for comment from our colleague and from Dr. Yasser, Dr. Ahmed, and Dr. Adil Al-Sayed from Al-Quwain Hospital. Thank you so much. See you next week, inshallah. شكرا دكتور يامن. تسلم الأيادي. شكرا رئيس.
شكرا دكتور محمد. شكرا دكتور يامن.